To obtain this bloodless aspirin, you have to ask the patient not to take any aspirin-like medications. You have to do the tumescent, plenty of tumescent at 28 milligrams per kilo for at least 1 hour. You have to allow 1 hour for the tumescent. In order to obtain this bloodless aspirin, the patient doesn't take any aspirin-like medications or any blood thinners. The doctor doesn't give any blood thinners or aspirin-like medications for at least 2 weeks before the procedure. The doctor tumesces properly, so the tumescent is abundant and in all planes with 1 milligram of epinephrine per liter. For a 360, we use about 6 milligrams of epinephrine in 6 liters, and we use lidocaine approximately 28 milligrams per kilo. Notice how I'm using my non-dominant hand. My strokes are very, very calculated and very slow, so it's very hard for me to penetrate an organ this way. Right now I'm going superficial, but you can go deep also. But even if you're not ambidextrous, this is very well calculated. I am pronouncing right now the anterior superior iliac crest here, the anterior superior iliac spine. So now I'm going to go deep on this side, and now you cannot see the cannula, but I'm pronouncing this iliac crest right here. We're going to do high definition liposculpture, but notice the aspirate, right? It's bloodless aspirate, and we can do this consistently and predictably. Thank you. Okay, so in order to obtain a bloodless aspirate, the patient has to stop or don't take any aspirin-like medications or blood thinners for 2 weeks prior to the procedure. The surgeon must tumesce appropriately in all planes and wait for 1 hour for the tumescent anesthesia to be tumesced before we start the procedure. I wanted to show them the aspirate, yellow bloodless aspirate. The strokes of the surgeon must be slow and calculated. This not only would limit the risk of internal organ damage, because what happens when there is internal organ damage is that usually the surgeon is fatigued, usually the surgeon is going at full speed, and the surgeon usually does an inadvertent, unintended stroke and goes in an area where he or she does not want to go. Similar to driving a car at full speed, especially if you're tired, you can lose control of the vehicle goes into an area that doesn't supposed to be, and then you have a problem. Thanks to God, we never had any internal organ damage, but I would say that it's almost impossible to do that, and I want you to focus on that aspirate. Take a look at that aspirate, and you see how this bloodless aspirate obviously will limit the risk of anemia, hematoma, infection, oil cysts, and even blowout fractures when you do a fat transfer to the body. Because I believe that this is also the result of aggressive liposuction and also 18 millimeters of mercury when you infiltrate into the buttocks. So the low pressure, slow strokes will minimize damage to the adipocyte. It will limit oil cysts, and also I believe that the body reacts to excess blood and excess oil and detects it as a foreign substance because it's outside where it's supposed to be. The blood's supposed to be inside the blood vessels, not into the buttocks, not into the abdomen. And similar to what happens when you have a capsular contracture on the breast, the body recognizes that there is excess blood around that breast implant, and it creates a reaction, and it gives you capsular contracture of the breast. Similarly, the oil detected on the fat graft is encapsulated. The body tries to get rid of it. The body acts like a foreign body reaction, like if you have a bullet or a piece of glass and the body wants to push it out. And I believe that that's basically the reason why oil cysts and blowout fractures occur. Of course, I agree with the fact that some of the fat may die, and that contributes to it. I also agree with the theory of disrupting the connective tissue in the buttocks and creating that blowout fracture. But I think I propose a new theory, which is that the body creates a foreign body-like reaction, rejects that oil, encapsulates it, creates an oil cyst. The body rejects that excess blood that you put. So we're toward the end of the procedure, and notice how we maintain this bloodless aspirate even toward the end of the procedure. Notice my strokes, how slow they are. This prevents not only internal organ damage, which we never had, but also minimizes injuries on the surgeon from repetitive motion. If you do liposuction and you do plenty of it, you're going to end up with tendinitis. And if you do it this way, you're going to avoid tendinitis also. So tennis elbow and shoulder issues and even carpal tunnel syndrome, all these can be avoided because number one, you go slow. Number two, you can switch hands. So I'm ambidextrous, but even for those surgeons that are not ambidextrous, if you do this slow, it's going to be easy, and you're going to prevent an injury to your patient and an injury to yourself as well. And we're doing high definition liposculpture. Let me show you how, to what level have we gotten. Okay, so let me have a lap here. So we're gonna dry this up, and I'm gonna show you the pinch test. So we're down to 0.5 centimeters everywhere here, 0.5 centimeters. And on this side also lateral to the semilunar lines. I don't know if you can see from that side. Can you see? Go ahead and get the camera, and so you can lift the camera and see this side. Alright, so the patient is on the left lateral decubitus, the buttocks are over here. And notice, again, my strokes are very slow. I'm using my non-dominant hand. I'm ambidextrous, but even if you're not ambidextrous, you can do these. And I would say the risk to the patient of organ perforation is minimal, even when you're going with the left hand or the non-dominant hand. Why? Because look at the strokes. They're very calculated. They're very slow. And look at the output. Can you see that output? I want you to focus on that output. Follow that output with the camera so you can see that yellow, beautiful output. On the side, the buttocks are over here, and we're going to do a fat transfer to the buttocks, but this is her waist. Look at the nice waist here. And this is the pinch test, right? So we're down to 0.5 centimeters all over. You see everywhere you go, okay? All over. So this is, and I'm going to do it this way too. I don't know if that's easier for you to see, or the other way is easier, but whatever it is, you know, it's no excess fat. Thank you. So we're in the lateral decubitus position. Notice how my strokes are slow, and notice how this is the last area that was to mesh. So we have much less, well, not much less bleeding, I would say, but I mean, oftentimes you would think that the last area would be more, you know, bloody, right? Yet we don't see that stuff. Thank you. Now we're doing ultrasound guided gluteal fat transfer. So we are transferring the fat, and I'm looking at the patient, and I'm also looking at the ultrasound. This is very important. I've been doing ultrasound guided gluteal fat transfer since 2019, and we have 15 centers where we're teaching doctors how to put the fat graft under ultrasound to minimize risk and complications. through the World Association of Gluteal Surgeons, and Dr. Alexander Earl, the World Association of Gluteal Surgeons president, has presented over 2,000 cases with no mortality whatsoever. So we put 100, and now what we do is we move to the other side. So, and I'm going to put another 100 here. We build laterally, and then we do the lateral compartments first, then the central compartment, and I'm going to talk to you about the inner compartments. Thank you. So in increments of 100, so I do 100 on one side, and we move to the other side, and I'm looking at the patient, I'm looking at the ultrasound, and I do this continuously with a closed system, so there's less risk of contamination of the fat graft. As you can see, this is, can you see the fat graft, how it's totally bloodless, so much less risk of losing the fat graft, because you know, you lose about 30 to 50% of the fat, you know, we tell our patients, right? Some of the fat dies or whatever, but I believe that a lot of it is that you're putting blood in there. If you put blood in there, obviously the blood is not fat, so our fat graft retention is almost 100%, and I believe the reason is that, and also much less risk of putting oil in here, and you don't treat the fat in any way. You just collect it in 500 ml of normal saline, and we're doing this under ultrasound guided in order to prevent a fat embolism. Usually happens when you hit the inferior or the superior epigastric, the inferior and superior gluteal veins. Inferior gluteal veins gets hit 80% of the time. Superior gluteal vein gets hit about 20% of the time, and this is universally fatal. 100. Thank you.
Alright, so as Dr. Patino said, this is a beautiful anatomy. We can see the striated muscle right here, which is obviously where we don't want to be putting any fat. And the subcutaneous space, which is defined by the deep gluteal fascia and the superficial gluteal fascia, this is where doctor can be putting fat. And this is Dr. Patino's cannula, which is kind of really right in the middle of both. He's wiggling it for us. And now he's going to show us the tip so that you can see what it looks like to put a bolus of fat into that subcutaneous space.
Okay, so here's the bolus of fat, so you're going to see some gray area going through, and what happens.
Alright, so you see how we have that gray, that's the fat coming in right here, and it's pushing down on the deep gluteal fascia. That's because the fat is entering the subcutaneous space. So you see the fat pushing in and the deep gluteal fascia getting pushed down. Even the superficial gluteal fascia gets pushed up a little bit as fat is entering this space.
And you can see that the superficial gluteal fascia has some breaks. It's not a continuous line. You can differentiate that with the deep gluteal fascia that has no breaks at all. And you can see the striated muscle. And you see the tip of the cannula again. Perfect. Thank you.
We have a gorgeous anatomy here. You can see the striated muscle right here and the deep gluteal fascia. And then we have the superficial gluteal fascia, which is right up here. And as Doctor mentioned before, there's a break sometimes in the superficial gluteal fascia, so you can see a part right there and there, whereas it's very linear with the deep gluteal fascia right here. Of course, there's already some fat in this space because we've already put some fat here. And for that reason, you see the gray and a little bit of a bulging down there. This is Dr. Patino's cannula. He's going to wiggle it for us. So you see a wiggle and it's a white structure. It's straight. This is the tip, and he's going to show us a bolus. So we got a fat coming in right here as a bolus. So you see how that deep gluteal fascia is getting pushed down as fat enters the subcutaneous space?
Awesome. And show also the skin and
up here?
Yeah. Very good. Thank you.